All right, so I'll hand over to you. Ese is a very good friend of mine, very passionate about the HIV response, and they've been doing a lot of work in Scotland. And we've known each other for many years, and they're really very, very passionate and very, very supportive as well. They've been doing so much over the decades in the fight against HIV/AIDS in Scotland and across the United Kingdom. So without wasting more time, I'll hand over to Ese and he's going to give us a presentation. Over to you. Welcome and thanks for the honor.
Thank you very much, Kingsley. Hi, everyone. I hope you're all having a good day, good start to December as well. So as Kingsley said, my name is Essie Johnson and I work in Waverley Care. I currently work in our minority ethnic communities project. Um, and just a brief introduction about Waverley Care. So we are a charity in Scotland that do sexual health and specifically HIV and hepatitis awareness, testing, and support for people living with HIV or hepatitis. And Waverley Care has been doing this work for the last 40 years. First of all, starting off from Milestone, which is in Edinburgh. Um, Milestone used to be a residential facility for people affected by a bloodborne virus. So, first of all, was HIV, but also hepatitis. So, people affected or living with HIV or hepatitis will be able to in the interim between moving from, well, it started off as a residential sort of end of life support for people living with HIV and who were dying of an AIDS-related illness when it started back in the 80s. And then over time with the medications that became available for treatment of HIV, the scope of work shifted gradually to supporting people between when they leave hospital or other intensive care and finding permanent accommodation back in their community. So Milestone stood as that middle point that helped people to get back on their feet. And you know, thank thankful to the work that has happened in Milestone, but also the work that has happened across the UK and globally in terms of HIV treatment and care. We've come to a place now where we don't actually need to run that facility anymore. So we'll be handing Milestone as an establishment to a different organization who will be working with another group of residential clients. And that's kind of how Waverley Care started. But we over the years we've expanded into doing awareness within different communities across Scotland. So awareness about HIV, awareness about hepatitis B and C primarily, um, talking to people about the changes in the science of these bloodborne viruses, talking to people about the changes in treatment and prevention options, helping people to understand, especially today, that a HIV diagnosis, is not a death sentence. Anyone, living with HIV now who has access to effective antiretroviral treatment is able to and gets an undetectable viral load is able to live a long, healthy, life, and they don't have to worry about HIV destroying their immune system as it would have in the past, and they don't have to worry about passing the virus on to other sexual partners. So it's quite a lot of changes that have happened over the last 40 years since the virus was first discovered. But surprisingly and unfortunately, there's still a lot of misinformation around HIV and the stigma that people then have to experience because of this misinformation around HIV. I'm living with HIV myself. I was diagnosed in 2019, and I think the main thing for me was, even though I went through a medical sort of training, and even though I had the up-to-date knowledge and information about, how the virus works and treatment and everything, I still carried a lot of stigma towards, the virus and towards myself based on what I'd heard, is what HIV actually is, hearing things like, oh, HIV is for, HIV is for gay men, or HIV is a punishment from God, or HIV, is something that people get if they are promiscuous, all of this wrong information that spreads around, in conversation or in interactions, and that's where we sit to challenge a lot of that misinformation that still exists today. Um, one of the most unfortunate things that we've had to deal with, especially over the last sort of 3 years, 4 years since we got out of the COVID lockdown, is funding shortages. So a lot of funding to our sector, the third sector in general, but also specifically towards the HIV and sexual health sector has, been on steady decline. There's been a lot of resources that we were able to provide and we were able to offer in terms of engaging with the communities that we work with around awareness and testing, but also the support that we offer because we also support people living with the bloodborne virus, whether that's around someone getting sort of getting used to a new diagnosis or getting to used to, I guess, living with a long-term health condition or a lifelong health condition, especially in the case of HIV, helping people to navigate that journey, helping people with sharing their HIV status with friends and family, but also providing some practical support because we all know like one health condition doesn't happen in isolation of everything else in someone's life. There's so many interconnected needs and there's so many interconnected, issues that people also have to deal with to be able to then say, I'm going to focus on my health. So we support people in addressing those. But over the last couple of years, it's been quite challenging. The decline in our funding sources, because we're largely funded by the NHS. The decline in these resources has meant, we've shrunk from an organization of, I think, about 80 something people last year to about 35 people this year. And, we're still going to be, losing some of our staff members once Milestone closes down fully in February. So it really is affecting how much we're able to do. Just looking at my side of the work, especially when working with minority ethnic communities in Scotland, there's a lot of issues now that people are experiencing around immigration, around housing, around financial stability that we know we don't have the expertise in. But because other organizations who provide this support are also overstretched, we kind of have to step in, but we really can't do as much as we used to be able to, because you have, one staff member, for example, working across an entire city trying to offer support to people. And it just is, it can be a drain on us. On anyone working in the organization at the moment, but not just to look at the challenges. We've also been able to look at some inventive ways, some creative ways to achieve good outcomes and to meet the needs that people have, with the little resources that we have. So, for example, when we look at community engagement work, before we used to depend solely on being able to go into community groups and organization buildings to have awareness and testing. But with a lot of organizations closing down, after COVID and after lockdown, because like I said, other third sector organizations are also experiencing funding cuts. So we had less places to be able to meet people and to be able to reach out to people. So one of the things we started doing was a health MOT day because we kind of thought of a health MOT as looking at your overall health and well-being. And so if we're able to bring together different health and well-being related organizations in one space at one time under the same roof, it's going to hopefully be an incentive for community members to say, I'm going to take this little time out of my busy schedule because I can get so and so and so benefit all at once without having to run to multiple different locations and speak with multiple different people, and not having to navigate that issue of, oh, I need this appointment and that appointment, but they are spread apart. I can't make both. Everything is in one space. And for the health and well-being, health MOT days or health and well-being days, we have blood pressure checks, blood cholesterol checks. People are able to get some vital sort of health data that then helps with advising on what next steps, whether people need to actively see their GP, make some health life changes, whether that's in terms of nutrition or sleep or diet. There's also information around mental health services. There's information from organizations that also offer services that are with sort of health conditions that are very important to minority ethnic communities. So if you're looking at cardiovascular related health conditions, so we have all of these different health services, and then Waverley Care being part of that, being able to offer HIV testing awareness, and we've been able to see more people coming to us to get a HIV test, an hepatitis test, than we normally would have experienced, when we were doing sort of standalone events just by ourselves. So it's been quite interesting, and we're able to reach a lot of people at one time with with the very little resources we have. Another project that we run at the moment is the infant formula program. So in Scotland, a childbearing parent living with HIV is usually advised, it's not compulsory, but advised to formula feed their baby from birth up until the first year. And this is one of the ways in which the NHS and Public Health Scotland have established, helping to reduce possible onward transmission of HIV. So we manage the service in Glasgow, in Lanarkshire, and also in Edinburgh, as well as a little bit of Aberdeen and the Grampian and Dumfries and Galloway. So we're able to, make contact with parents who've just had their children, offer the free formula milk, as well as the equipment they need to be able to formula feed their babies, so sterilizers, feeding bottles. But it's not just the equipment, it's not just the food, it's also the support for anyone who might be going through, something that they can't discuss with anyone. Because if we're looking at a parent living with HIV, most times on this project, people only find out about their HIV status during their pregnancy. So maybe from their antenatal care is where they got tested and where they found out. So it's still very new to them. They've probably not even been able to, talk to close family and friends about living with HIV. So we're also able to help people on that journey, as well as navigating being a new parent, or being a parent for the second time, third time. Every time it always comes with, its own different peculiar challenges, and we're able to be there and offer as well a close group, or for these parents to be able to come together and discuss, things that involve raising a family and living with HIV, and just trying to be people who are going about their day-to-day lives living well with HIV. Um, the last project I will just touch on is, or the last thing I will touch on is our engagement with people already living with HIV and hepatitis around one-to-one support and group support. So we have our staff who meet people directly and are able to offer support, but we also have, for minority ethnic communities, we have a group for it's called the Health and Wellbeing Group, and it's basically set up for people to be able to socialize, make friends, meet other people living with a bloodborne virus, but making it less of a clinical space. It's like you already go to your clinic and you have conversations with your clinician. You already probably, are overstretched with talking about HIV, hepatitis. We just want people to be able to come and be themselves and just interact with other people. And if the subject matter of HIV, hepatitis comes up, then you have a conversation about it. But it's an opportunity to have a community that is real and is not just centered around one part of someone's lives. It's like there's so many things that make up individuals. There's so much that people want to share with other people, being able to integrate and make friends and build a social circle, go out and do activities together. That's what the group is about. And then that improves people's health and well-being, because people say things like, oh, when I found out about my HIV status, I isolated myself from the rest of the world. I thought this was the end for me, but this group was the chance for people to be able to start building a connection with someone that then led to them feeling like, oh, I actually can have a beautiful life. I don't have to worry, but I don't have to hide myself away. I don't have to, think that this is the end. This is just the start of a new journey. And those are the ways that we're trying to, work around the challenges. Obviously, there's global challenges that are, impacting on the HIV sector and people living with HIV. And those are things that we're beginning to see little by little. And I'm sure Kingsley will be telling you more about that. But I think the main thing for me to say to everyone on the call today is to take a proactive approach to speaking out, Because if it's only people living with HIV or people directly affected by HIV who are talking about these challenges we're facing, then our voices probably wouldn't go as far. But if everybody, regardless of their HIV status, regardless of your background, regardless of who you are, where you're from, if we're all talking about the fact that this is still something that we need to be focusing on, then hopefully things will be conversations will continue to happen and things will begin to change, and we'll be able to offer better supports to people living with HIV and other long-term health conditions. I'm just going to stop there now, and I know I've kind of run over time slightly, so if anyone has any questions, I don't know if we have time for that, Kingsley, or
Yes,
if
yes, yes. There's time for questions. If you have questions, you can unmute and ask your question.
okay,
You can also
perfect.
put it on the chat box.
Yes, exactly.
Maybe while we're waiting for people to reflect on what you said and draft their questions. So practically, what supports with the difficulty in funding, are there certain services that have suffered as a result of that? And what kind of strategies are you advocating in terms of being able to overcome, the changing funding landscape?
Yeah, so I mentioned other third sector organizations are experiencing challenges. We used to have a lot, especially in larger cities like Glasgow and Edinburgh. We used to have quite a lot of integration networks or integration groups, mostly helping people to, especially newcomers to Scotland, to be able to settle in, build a community, find jobs, secure good accommodation or housing. We used to have a lot of these groups, but most of them have had to, either shut down or pivot their sort of their area of focus over the last couple of years. And obviously, like I said, having a health condition doesn't exist in isolation of life's other challenges. It's all interconnected. So, sometimes we have conversations with people say, and people are like, oh yeah, I'll think about getting a HIV test later. Right now, I'm on my way to, go and do this and do this. And, I'm on my way to citizen advice to be able to sort this out. So it's like we understand how there's other priorities on people's list, and probably HIV is number 20 or number 30, a HIV test or finding out more information. So what we try to do is we're trying very well to work with people we trust who we know also care, because there's organizations that sometimes do not really care about the people they work with, you know, unfortunately, and that's just the bitter truth. So we keep good connections and good relationships with organizations we know really care about people and are not just like tokenistically saying this is what we've done, ticking boxes. And we try to then help people into those services. And they do the same, just last week, a staff member from LGBT Health and Wellbeing, which is an organization we work very closely with, gave me a call. There's someone living with HIV. They've just moved here. They don't know where to go get their treatment. They're worried about running out of tablets. I was like, okay, yeah, send me their number. I'm going to give them a call, help them to get what they need speedily, quickly. And those relationships is what, being able to solve someone's problem in as easy as a phone call rather than sending them through so many different hoops of you go on this website and then you fill this form and then you wait for 2 weeks and then you come back and you have an assessment. Putting all of those things in people's ways just makes people think, you know what, I'll deal with this later. I have something more pressing to deal with right now. So that's one of the ways that we're addressing this challenge. Yeah.
Thank you so much. You're highly appreciated. It was a fantastic talk, and I believe that there are more and greater things in store for 2026. Um, Despite the challenges with the funding, we know that part of this program is also to raise awareness so that we can be able to continue to raise more funding and continue to raise more awareness about HIV/AIDS. That is still something that needs to be resolved. It still requires funding. It's not yet over. And so thank you so much
No
for the
problem.
fantastic work of Waverley Care. You're highly appreciated. Thank you so much.
Thank you very much.
I can't. Okay. Okay, there's some questions. Sorry, I'll hand over back to you.
Oh,
There's
yes, let me
one
just quickly
question.
read that.
Hold on the chat box. Okay, so what have you found? So this is from Jaylan Merkel. What have you found are the best ways to amplify voices and raise awareness of HIV? And what messages would you like to see prioritized?
One of the easiest ways, and I say this for anything really, not just HIV. One of the best ways to anything that involves a lack of understanding, and is such a big cultural or societal issue. One of the easiest and the best ways to be able to change perceptions and raise awareness is by having community leaders. And I don't mean community leaders in terms of just like politicians or, I'm talking about people who others trust. And that could be the head of a family. That could be the person you know in your community that all the people call mommy or all the people call auntie. It could be a pastor. It could be an imam. So people who are really, I call them the pillars of influence. If these people can speak openly, plainly, and positively about HIV, it's going to change the minds of a lot of people because I imagine if I look up to someone for guidance, for leadership, for wisdom, and the person comes to me and tells me, by the way, do you know this thing about HIV that, I've heard if you take your medicine, you're on treatment, you become undetectable, you can't pass the virus on. I will be much more interested in listening and actually dwelling and reflecting on what has been said because it's coming from a place of trust and a place where from someone who I highly regard rather than just one of the things you see on the internet or so, because there's so much information out there, no one knows exactly what to even focus on anymore. And I think that's one of the issues. There's too much information. Everyone is, constantly bombarded by messages that it's like you only really tune into the ones that feel legitimate. And how does it feel legitimate if it comes from a source you really trust? I feel like that's one of the things we can do. And then there was another part to that question, and that involves as well people of influence living with HIV. If people of influence living with HIV are able to openly say, I'm living with HIV, and it's difficult, we understand that. Um, but it's one of those situations where I always say sometimes, no one cares about the problem more than you who has the problem because it's your problem. It's like if we hide away alongside with the rest of the world, hide away from talking about HIV, we suffer more because we are the ones living with HIV, experiencing, some of the stigma and some of the shortages in services that we need to be able to live healthy. So, if there's anyone in the audience who's living with HIV and you have a sphere of influence, which I believe everyone does, please use it, utilize it to spread the messages that we're putting out there. And what messages should we prioritize? I think the key one is HIV has changed significantly from what most people remember. Because I think most times when people have the outdated knowledge of HIV, it usually always ties to the first decade, which is when people were progressing to AIDS-related illnesses, when there was no treatment, when there was no care. So people immediately always jump there most of the time. And so if we prioritize that message of HIV is no longer a death sentence, if someone is living with HIV, and they are on their treatment and become undetectable, which means the virus is so little in their body that they cannot pass that virus on to someone else sexually, even if they don't use a condom. If you tell people that constantly and you back it up with stories, like for example, with myself and my ex-boyfriend, he knew all the information and there was no worry. But at the end of our relationship, we're still very good friends. So I said to him, I'm going to get you a HIV test. I want you to do a HIV test in front of me and let's test this undetectable equals untransmittable, thing. I know it's true. We know the science is true, but nothing changes your mind quicker than something you experience for yourself. And he did the HIV test and it was negative. And I'm like, that is something I can always take forward as this message is true. This message is real. So that's the thing. You can pass it on to someone else sexually if you're undetectable. And also, HIV is no longer a death sentence.
Okay.
There's another question that says, what
So,
motivated you to fight for this cause? So, I got diagnosed in 2019, back in Nigeria, and I remember, like I said, I studied human anatomy for my undergrad, my undergraduate degree. I knew all the science about HIV. I knew about treatment, I knew about medication, I knew I wasn't going to die. But when I got my HIV diagnosis, and I almost never tell anyone this particular part. I think there's only one person I've told this before. I wished there was no medication when I found out about my HIV status, because then I knew that the virus would destroy my body and then I would die someday. That was how much shame I felt about being diagnosed with HIV. And so I remember then a year on from that, I was listening to, it was a year and a half. It was on World AIDS Day in 2021. Or in 2020, I was listening to someone share their HIV story to a group like this online. And I remember feeling like I got wings in that conversation, because I remember feeling like, why am I so ashamed about this? Because it's just a virus that I happen to have picked up somewhere, just like any other virus. Why did I have to feel like I wish I was better off dead? And it was in that moment I realized there's probably someone else feeling that way. And there's people who have unfortunately gone as far as to actually end their own lives because they just can't live with the shame and the guilt that they feel, whereas there's nothing to be ashamed of. And so that was when I decided it's time to, use my experience and take some of that message back into my community and make sure no one else has to, go through a process of thinking such, horrible thoughts. You're welcome.
I said, thank you so much. Well, that was very, very touching. Really appreciate. Yeah, and Sarah Davis says, amazing revelations. I say, thank you and praise to thee. Esther says, God bless you. Wow. Thanks so much, Asa from Gillian. Wow, so that's a very, very touching testimony. Thank you so much for the great work that you're doing. And I know that you're reaching out many lives. Just as somebody else inspired you, I know that you're inspiring somebody. Someone else is going to watch this and is going to be inspired. So thank you so much. You're highly appreciated.
Thank you very much for having me. Unfortunately, I'm going to have to run because World AIDS Day is quite a busy time in Waverley Care, so there's back-to-back events. But thank you so much for having me, and hopefully see you all again in the future.
Thank you so much.
Yeah, thank you. Take care. Bye.
Welcome Victoria Azodo from Nigeria, from Ministry of Health. Victor also from Dundee, public health with the Faculty of Public Health, Royal College of Physicians. Sarah Davies, you're welcome, from Scottish Government. We work together in Global Citizenship Fund. Thank you so much. Gillian Merkel, I think also from Waverley Care. Esther Welsh, you're welcome. And Dania Niati, you're welcome as well. Onyinyechi, also from ASDO, African Scottish Development Organization. So thank you all for making it, and we are all highly appreciated. If, as the presentation is going on, you can leave comments in the chat box. You can leave your questions. At the end, we'll take final question and then we'll close. If you're able to stay to the end, you get a free copy of one of my books, Role of Donor Agencies in Combating HIV/AIDS and Tackling HIV-Related Stigma, a Global Public Health Perspective. So I'm going to give a presentation now. We'll take discussions and then we're going to close. So we're not going to take too much of your time. Thank you so much. I'm going to share and I'm going to share a slide. Click the share button. Are you able to see the slide? If you can see the slide, somebody say yes so I can know. Or type something in the chat box. Okay, thanks, Daniel. Okay, yeah, so my name is Kingsley Oturu. I'm going to be talking today on overcoming disruption, transformation, and the AIDS response. So this is from UNAIDS theme for this year for World AIDS Day. So this is December 1st, 2025. So I have a medical background, a PhD in international health and development, and with the African Scottish Development Organization. I've been very, very passionate about HIV/AIDS right from when I was in medical school. I would go to secondary schools to talk to people about HIV/AIDS. And one day I was in a restaurant and a young lady came to me and said, "Wow, thanks, you changed my life when you came to my school and you talked about reproductive health." So there was really that passion, and that I was really touched by that. And I continued, my master was looking at the role of donor agencies to combat HIV/AIDS in Nigeria at Queen Margaret University. And I did my PhD looking at access to antiretroviral therapy in resource-poor settings. So it's something that I'm really very passionate about. Nobody should be discriminated against based on the HIV status or any clinical condition. So I'm going to be talking from a global health perspective, looking at global HIV progress, the funding disruptions in 2025. What impact has this had in terms of prevention, treatment, and in communities? What are the current signs and strategies of resilience? And then we'll end with the call of action to action for Scotland and Africa. So AIDS means the acquired immune deficiency syndrome, and is caused by the HIV virus, the human immunodeficiency virus, which damages the immune system so that the body is less able to fight infections and disease. So if untreated, the immune system becomes weakened to the point where it progresses to AIDS. And there's no cure for AIDS, but there is a treatment, the ARVs, antiretroviral therapy, that reduces the risk of HIV transmission. HIV is mainly transmitted through sexual intercourse, such as sex without a condom, through the blood, things like blood transfusion, sharing needles and syringes, and then also through vertical transmission from mother to child during pregnancy, childbirth, or breastfeeding. And even though there is no cure, there are medications for keeping the disease from getting worse and for reducing AIDS deaths around the world. And apart from reducing AIDS deaths, the ARVs also reduces the risk of HIV transmission. So if somebody is HIV positive on ARVs and the viral load is undetectable, the latest studies suggest that it reduces the risk of transmission of HIV/AIDS. So there are ongoing efforts to prevent and treat HIV/AIDS, especially in resource-poor settings. So globally, what is happening? At the end of 2024, we are at the edge of ending AIDS as a public health threat by 2030. 77% of the people that were HIV positives were already on ARVs. That's 31.6 million out of 40.8 million people. There was a 40% decline in new infections since 2010, 54% decline in AIDS-related deaths, and pre-exposure prophylaxis success in places where coverage was high. And as of the end of last year, as of the end of 2024, the Global Fund to Fight AIDS, Tuberculosis, and Malaria had pledges of about $11.34 million US. Globally, domestic HIV financing had increased by 28%, while international finances had increased by 12%. And the global annual number of new adults living with HIV/AIDS fell by 36%. So between 2010 and 2024, there has been a massive progress in terms of the global response to HIV/AIDS. And this graph is from UNAIDS showing their special analysis in 2025. And you can see that there has been a gradual, steady reduction in the number of new adults living with HIV/AIDS from 2010 to 2024. I'm speaking to people even in 2024, the last word is the people are like, it's no longer a challenge, it's no longer a problem. rightly so, people are now living longer. People are now on ARVs. People are living normal lives. The life expectancy has increased remarkably, and people can now live normal lives by just taking the antiretroviral drugs, the anti-HIV drugs. However, there was a disruption in 2025, around January 2025, when the US suggested that they are cutting international funding. And other countries like the UK also followed suit. So globally, there was a reduction in funding for about 30 to 40%. And the USA, mainly through PEPFAR, halted 75% of global HIV funding. This led to clinic closures, staff furloughs, and millions around the world losing access to pre-exposure prophylaxis, prevention and treatment programs, and putting the 2030 targets into chaos. As of the end of 2024, 11 million people already had unsuppressed viral loads. And there was a 95 target, which the UNAIDS has set so that 95% of people living with HIV/AIDS know their status, 95% are on ARVs, and 95% are virally suppressed. And that if this is maintained and sustained by 2030, HIV/AIDS will no longer be a public health problem. And as of the end of 2024, 89% of people living with HIV/AIDS knew their status, 94% on ARVs, and 94% virally suppressed. So we're on track for zero transmission by 2030. And as you can see from this chart, this was an estimation by the UNAIDS that by 2030 we needed 21.9 billion US dollars annually to ensure that we're able to check the HIV/AIDS pandemic. If you look at the next graph, you find out that in terms of exposure to international donor funding, if you look at places like West Africa, Central Africa, you can see, for example, early infant diagnosis, pediatric antiretroviral therapy, 100% dependent on donor funding. Health system strengthening, 100% dependent on donor funding. Prevention efforts, 91%. And so they are at increased risk when this funding was drastically reduced. So this is in contrast to places like Latin America, where there's less dependence on donor funding. So this is a graph, a chart from my master's, or looking at the different strategies from different organizations and how they engage with international development. So this was adapted from Susan Fustukian's framework. The World Health Organization tends to work with states, like the Ministry of Health. They ensure that the state has maximum involvement, focusing on health as a right of citizenship that is not dependent on income or wealth, and focusing on sustainability that meets the needs of the present without affecting that of the future. The UK tends to focus in social groups and communities, pro-poor, pro-vulnerable groups, looking at redistribution of wealth, working with civil society, but is now gradually also working with state structures and requiring contributions from the community. While USAID tends to have a neoliberal approach, free market economy approach, favoring working with NGOs, civil societies, and even do work with private hospitals and the state. They tend to be fast, high quality, and meet the needs of the present, but may not meet the needs of the future when funds are not forthcoming as we have at the moment. So some strategies I mentioned that initially, I think, like pre-exposure prophylaxis. So this is a preventive strategy whereby people who are HIV negative can take the ARVs before potential contact with the virus and stop the virus from multiplying. So it's usually recommended with people where you have serodiscordant couples, one person is HIV positive and the other is negative, especially if the viral load is unknown, people that have sex with multiple partners, especially without condoms, men that have sex with men, commercial sex workers, and people that use drugs and needles. And also people that have had a recent STI diagnosis. So it's on a case-by-case basis, and it depends on the country in which you are in. But basically, the PrEP helps to prevent, is another strategy that helps to prevent HIV transmission. So what is the human impact of the disruption in funding? The United States President's emergency plan for AIDS relief, some aspects have been restarted, but there have been other service disruptions and funding cuts. Women and key population have been hardest hit. Women living with HIV/AIDS, pregnant women receiving ARVs have had their medication stopped. There have been increased incidents of mental health distress, loss of peer support networks, and HIV/AIDS test kits and condoms have been lost. As of 2.5 million people who used PrEP in 2004 have lost access in 2025 due to the donor cuts. So that was as of 15th of October 2025 from the AIDS Vaccines Advocacy Coalition. Other impacts of the disruption, PrEP access has been reduced by up to 64% in some countries. In Nigeria, condom distribution fell by 55%, and voluntary medical male circumcision dropped significantly. Male circumcision has been demonstrated to give 60% protection to the males from contracting HIV/AIDS. Also, adolescent girls and young women are at high risk. They contribute to 25% of all new infections. So 50%, there was a 50% reduction from 2010 to 2024. But we now have about 570 new infections daily globally among adolescent young girls and women. So 9.2 million people are still not on antiretroviral therapy. There have been declines in HIV testing of up to 43% and disruption in viral load and CD4 monitoring, with many clinics having staffing shortages due to the disruption in funding. Most community programs rely on donor funding, some up to 90%, and many have been forced to close their services. Women-led organizations have been severely affected. In places like Tajikistan, community groups have lost funding, and community groups are the only places where people trust. 20% of funding were provided by PEPFAR up until January 2025. So it's having an impact in community-led responses. And also there's rise in punitive laws, increased criminalization of HIV, and the vision for zero discrimination is anchored on global 2025 targets being met. So as you can see from this graph, so this is from UNAIDS, and the graphs in red show areas where there's criminalization of HIV transmission. So that includes places like in West Africa and also in the United Kingdom. So what has been the response to all this chaos? The African Union Roadmap to 2030 is providing alternative sources of funding to help to meet with this change. We have the Accra Reset, Health Sovereignty, new local manufacturing initiatives, and domestic financing is increasing in many countries in response to this. So on the one hand, it's a lot of lives have been affected and have been lost, but then at the same time, a lot of countries are now adapting to this new threat. International donor funding supply about 80% of funding for human rights programs. And a lot of countries have an increased debt to GDP ratio, especially in resource-poor settings post-COVID. But there are some new country actions in places like Nigeria, Tanzania, and Cote d'Ivoire. They have increased their HIV budgets. Kenya is sustaining ARVs through domestic expansion, producing ARVs. Vietnam, Thailand, and Philippines are using national insurance schemes to fund antiretroviral therapy. And the Global Fund teams are working with different countries in using the rapid aid financing tool to identify areas where people should focus more on. Should they focus more on treatment, more on prep, more on prevention, based on what the data is saying. So that's the RAFT tool. In places like Uganda, King Mutebi is providing high-level leadership, ensuring that things like sports are used to raise more awareness about HIV/AIDS. And there's greater multi-sectoral collaboration in Guatemala and integrative national responses in Nigeria, with moves to produce ARVs and test kits locally. So the top line targets are still there for 2030, ensuring that, for example, 95% of people living with HIV/AIDS know their status and they're on treatment, and that they have 95% have suppressed viral load. 95 target. But we still need resources. Resources are still needed to tackle the HIV pandemic. The amount of funding that was needed has actually reduced. Was initially projected to be about 29 billion US dollars annually, and this has reduced to 21 US billion dollars annually because of improvement in testings, service delivery models, the provision of generic drugs that are cheaper, but the efforts still need to be ramped up. So this is some modeling that has been undertaken by UNAIDS, that if the current funding continues, we'll be able to meet our 2030 targets. As you can see, the number of people acquiring HIV is reducing almost to zero by 2030. But if the disruption continues, we are going to see an increase in number of new infections. So that between now and 2030, we have about 3.9 million new infections globally, and it's going to have impact on different countries, including the United Kingdom and Scotland. Scotland still remains committed to zero transmission by 2030, and we need to have policies protecting people living with HIV/AIDS from stigma. In places like in the NHS, people still experience stigma. And one of the key recommendations that I'm suggesting is that in the equality and diversity policies, it should be stated clearly that people living with HIV/AIDS should not experience discrimination, because it falls under disability as well, because people are still reporting discrimination and stigma in the community and even in the healthcare system. We need greater involvement of African communities, continued partnership with organizations such as Waverley Care and the African Scottish Development Organization. And we need to keep pressing on for continued donor funding, tackling HIV abroad and in the UK. We shouldn't see it as something that is out there, because we are now living in a global village, and whatever happens in other parts of the world will have an impact in the UK, in Nigeria, in Kenya, all over the world. We've seen that with COVID. We are living in a global village. And we can also harness innovation, harness technology, artificial intelligence in modeling and in providing solutions moving forward. Long-acting injectable ARVs is another strategy. The Gates Foundation is working with Indian companies to provide generics, and it's costed that with these injectable ARVs, it will cost about $40 per person per year, which is quite affordable, in tackling the epidemic. So that is another strategy that is being looked into globally. So ASDO, the African Scottish Development Organization, is also working in terms of advocacy for diaspora communities. We're very, very passionate about stigma reduction, raising awareness on HIV/AIDS, and also mobilizing African Scottish partnership to raise awareness, raise funding, provide equipment to support people living with HIV/AIDS, both in Scotland, United Kingdom, and in Africa. So we need to rebuild prevention systems We need to strengthen diaspora engagement, and even with the Scottish government, continued donor support. We need to continue the advocacy, and we need to continue to invest in community-led responses in Scotland. So AIDS is not yet over, but together we can overcome disruption. So join us as we transform the AIDS response. Thank you. So if there are questions, we can take them, or comments. If you have any questions or comments, you can put them in the chat box. Any questions or comments? Okay, Victoria, what is your question?
Yeah, good evening. Thank you very much, Dr. Kingsley, for this very insightful presentation. My question is, since HIV is not, by the grace of God, we're running towards getting a cure for it. I'm just wondering, what are the ways in which we can ensure that the stigma is reduced? Because it's not even the only disease that has issues. There's hepatitis, and there are other ones. But why is it that HIV-AIDS seems to be the most disease that has a lot of stigma, especially in the West African region?
Well, thank you very much. That's a fantastic question. Yeah, so the research suggests that there are a lot of reasons. Firstly, when HIV/AIDS came up in the 80s, in 1980s, a lot of the adverts, a lot of the health promotion, was casting HIV/AIDS as something that may be due to witchcraft. You see skull bones. There was that link to death. A lot of pictures of people emaciated. So there was just that negative stereotype that was provided, during the initial period. Then also the mode of transmission as well. If somebody has cancer, there's that feeling that, oh, it's not their fault, they just had it, But then if somebody has HIV, there's that perception, oh, the person must have engaged in an immoral sexual activities that now led to them getting the HIV/AIDS. So it is their fault, Even though we know that there are people that have gotten HIV/AIDS, maybe through blood transfusion. There are stories about people who, for my PhD research, some people, a lady that was a virgin, got married to someone that was HIV positive and got HIV through that means. So it was really through no fault of theirs. But because of and then the invisible nature of HIV/AIDS, so all these factors have all played into the stigmatization. And in places like Africa, there was superstition about role of witchcraft and all that. So all this have all played into the narrative that has caused HIV stigma. And so even in the healthcare system, even in the UK, as I was mentioning, some people have experienced HIV stigma even in the healthcare system. So that's why I wrote the book, and it also draws on my PhD research on HIV/AIDS. So part of the strategies, one of the things that I did was to conceptualize stigma. There are different levels of stigma. So from the research, I found out that there were different levels of stigma. On the one hand, you have like what Asa was mentioning early on, self-stigma. So some people who are HIV positive may feel that everybody knows about their diagnosis. They begin to isolate themselves. So people can stigmatize themselves. So that's self-stigma. And then you have familial stigma. People in the family can stigmatize someone who is living with HIV/AIDS. So, you'd expect that the family members will support, but from the research that we did, we found out that a lot of family members actually stigmatize, their family members. So somebody is HIV positive, they wouldn't want to eat with them. They would drive them away from the house, you know. And then we have what is called organizational stigma. So that is where the organizational arrangements in the healthcare system inadvertently stigmatizes the patient. For example, when I was doing my research in Nigeria, there was a hospital that was funded by PEPFAR in Abuja, and there was a section that was separate from the main hospital. So when people want to get the ARVs, they have to go through a bushy path to that section, you know, that was separate from the main hospital. So anybody seeing going to that place, everybody knows the diagnosis. So that's an inadvertent form of stigmatization, organizational stigma. And they have institutional stigma, where the institutional arrangements, you know, directly stigmatize people. Like in some banks, they wouldn't employ someone that's HIV positive. Some schools will not give someone that's HIV positive scholarships. So that's what I coined institutional stigma. So it means taking each of those levels and then adapting the strategy based on what the type of stigma is. So self-stigma, people have to be supported psychologically, you know, provided with self-help to improve their self-esteem. Familial stigma, people have to engage in family therapy. More awareness needs to be raised in churches, in mosques, in the schools, in the healthcare system. Institutional stigma, we need more awareness in the different healthcare systems, and also legislation as well to protect people living with HIV/AIDS. So it depends on the type of stigma, yeah. But generally, raising awareness is very important, and providing legislation to support people living with HIV/AIDS. And then I also mentioned earlier, in the policy document, for example, in the UK, there's a Equality Act that ensures that nobody should be discriminated against, you know, irrespective of age, sex, gender, their healthcare status, disability. And HIV/AIDS is, you know, is under disability. So one of the easy ways is to ensure that HIV/AIDS is written clearly in the policies, in the equality and diversity policies, in the NHS and other public health organizations, that there should be no discrimination. So thank you very much for that question. So there's another question. So you have a question, you can raise up your hand so I can see you, or you can put it in the chat box below. Okay, I think I'll take from Esther first. So Esther, what's your question?
Praise God.
Thank you. Yes.
I was wondering, what was one of the first treatments given for someone who had just been diagnosed?
Yes. Thank you very much.
Thank you.
Yeah, that's a good question. Initially, when there were no ARVs, it was just palliative treatment that was given to people living with HIV/AIDS. And then you had different drugs that came on board. There was a non-nucleotase reverse transcriptors, and the nucleotase reverse transcriptors, protease inhibitors. You know, so initially individual drugs were being given to patients, but then later research now found out that when the antiretroviral therapies are combined, that they have a greater impact in tackling the HIV virus. So that's why we now came up with the antiretroviral therapy, combination therapy, where we use 2 or 3 different medications working together to attack the HIV virus. Yeah, so initially there was no medication, it was palliative, individual antiretroviral drugs, and then we now had combination therapy. So now we're now at the point whereby when people take the ARVs, it can reduce the viral load to the point that it becomes undetectable, and they are unable to transmit the virus, you know, to their partner or to their child during pregnancy. Yes, Onyinye, you have a question? I can see you raising your hand. Do you want me to read what you wrote, or you want to say it verbally. He said, do you think there should be more inclusion in school curriculum on HIV/AIDS education as people still act uninformed, thereby contracting and spreading the virus? Yes, I think that is a very, very good point. And on reflection, when I was in the secondary school, I'm not sure I received much information, even in the university. It was actually an external person that came in and gave a talk. There used to be a drama called Second Chance in Nigeria, and one of the actors actually came to the school and gave a talk. He kind of gave a kind of jingle of what HIV/AIDS was. I think that was one of the key factors that actually motivated me to do something similar. So when I went to medical school, I would go to secondary schools and I would give them talks on HIV/AIDS and on their reproductive health. But I think that's a very good point. But is there a point for there to be more inclusion in the school curriculum on HIV/AIDS education? So I think that there is that point. So depending on where you are in the world, there will be different levels of inclusion. But just reflecting on my medical education, on my education from primary school, secondary school, university, until when I went to into the medical school, there wasn't really much in terms of including HIV/AIDS in the curriculum. So I think there is a good point there for greater inclusion in the educational system. And also, when people start working in the NHS, for example, in the healthcare system, there should be greater integration, like during the induction and onboarding. People understand what HIV/AIDS is, the need not to stigmatize and discriminate. So I think that's very, very important. So that's a very good point that you've raised. So thank you so much. So Esther, your hand is still up. I don't know if it's a legacy hand, or you have another question. Do you still have another question, Esther?
No, that was very well explained. Thank you so much. It's just that I was born in 1985, and I was I received a blood transfusion at the time, so it was something. Yeah, it was really something. And I really thank God that we came where we are now, and that people are treated.
Your voice has gone down a little bit.
Can you hear me?
Okay,
yeah, I said I really thank God that people have been treated now better than ever, and that we are overcoming this disease. And like you were saying earlier, it was highly stigmatized back in the 80s, even in the 90s. And it seemed that, once you had it, you were going to die, and that was the end. That was the end of your life. And we really came far. We really came far, and I pray that it will be completely cured in Jesus' name. We'll find a cure in Jesus' name.
Amen. Thanks so much, Esther. So on that good note, we'll gradually come to an end. Thank you, Esther. Thank you, Dinah, Nyati, Oninye, Gillian from Waverley Care. Thank you so much. Oninyechi, Victor, Victoria, thank you so much. You're all highly appreciated. And I'm going to send you the books. I'm going to send you a copy, Tackling HIV-Related Stigma, and the role of international donor agencies in combating HIV/AIDS. We're going to get it free. So thank you so much. We've had a fantastic time, and we'll keep in touch. If you want to contact ASDO. You can go to our website, www.asdoonline.org.uk. That's asdoonline.org.uk. You can also contact me at kingsley.oturu@asdoonline.org.uk. And yet, the recording is available. Somebody is asking, we'll send you the recording as well. The recording is available and is also on Facebook Live. So we'll send that to you and we'll upload it on YouTube. So thank you so much. Let's continue the fight. Let's continue supporting and solidarity against HIV/AIDS. Thank you so much. Happy World AIDS Day. Have a lovely day. Thank you. You can unmute if you want and say bye. Bye, everyone. Bye. Thanks so much, Dania. Nice to meet you.